So very good morning to all of you. We are going to, yeah. So the topic of discussion, are we still ignoring type B aortic dissection? In few minutes, I'll try to tell you that no, we are not. The cardiovascular conditions, the incidence has been increasing significantly over the past few decades. And not unlike coronary artery disease, valvular heart disease is also on rise, and so is the diseases affecting aorta. Unlike congenital heart disease, which is fairly static, as you can see. The incidence of acute aortic dissection is also on rise, and not only this decade, you can take any country, the incidence of aortic dissection, even thoracic aortic aneurysm and dissection, everything is on rise, and operations are also on the rise. Initial management of suspected acute aortic dissection is outlined somewhat over here. Once the dissection is confirmed, if it is type B, it used to be continue medical management. But then it has evolved from 2000 onwards, 2002 onwards, or I would say specifically 1999 onwards, because 1999 was the first case report in NEJM when type B aortic dissection was repaired using TAVR. Until then, the surgical treatment used to be really morbid and had high mortality. In fact, higher mortality compared to medical treatment. So this particular case, which was reported in 1999, showed that there was good amount of aortic remodeling after the TAVR. The true lumen enlarged and false lumen completely thrombosed. But we quickly realized that the type B aortic dissection is not a homogeneous entity. Type B aortic dissection can be low risk, uncomplicated, without any hemodynamic compromise, without any ongoing chest pain, without any evidence of malperfusion of the organs. And type B can be with all of that, hypotension or malperfusion or ongoing chest pain or quickly enlarging false lumen. And these high-risk patients did not do well. In even first 30 days, the curves start separating and they have very high mortality. So survival with acute type B aortic dissection on drug had a curve like this, where it was significantly going downhill over a time period. And this curve was going downhill not only in first 30 days, but it goes down across all 5 years, 7 years of follow-up. And it depends very much on the medical management also. So chronic type B dissection on drugs can look like this, and sometimes it is very ghastly and it becomes very difficult to treat once it becomes chronic and complicated. The INSTEAD trial tried to or attempted to answer this question, what to do with type B aortic dissection, which is uncomplicated. We had realized that complicated type B aortic dissection is best treated by endovascular repair, and if it cannot be repaired with endovascular procedure, then surgery came into picture. But medically, you can't manage these cases. Instead, tried to answer that question, that what happens to uncomplicated type B aortic dissection if we subject them to TAVR rather than medical management. And at 1 year, crossover rate was 14%, 2 years crossover rate was 20%. The survival curve did separate, but there was no significant difference between TAVR and the medical management. So the take-home messages from INSTEAD were that probably both are equal, though there were signals that aortic remodeling was better when the TAVR was performed. Freedom from progressive aortic disease, there was a signal that TAVR was doing better. But then instead Excel came when they performed a 5-year follow-up of instead patients. And then the curve started separating. Because in instead Excel, they could show all these were instead was a randomized control trial, but the number was small. But still, they could show that over a period of 5 years, there was a long-term advantage of endovascular procedure with true lumen enlarging, aortic remodeling more favorably happening. The quality of life was better. And then the data from IRAD, the registry, ongoing registry, came that the survival curves also probably were separating. Adsorb also was a trial which showed that there were signals that endovascular procedures are better. Simultaneously, amongst the devices, also there was evolution or revolution. There were so many devices available. And finally, by 2014, the guidelines looked something like this, that in uncomplicated type B aortic dissection, medical therapy should always be recommended, class 1 indication with level C of evidence, but TEVAR should be considered recommendation class 2A with level of evidence B. In complicated type B aortic dissection, TEVAR is always recommended, which is a class 1 recommendation. And in complicated type B aortic dissection, where TEVAR is not possible, surgery may be considered, which was a class 2B recommendation. So by 2014, we knew this. And this knowledge percolated everywhere amongst all the guidelines by 2017. And slowly we have started talking about more evolving indications for type B, that not only cardiogenic shock, not only perforation, but ongoing chest pain, intramural hematoma, certain CT features came into play, which tell us that it is better to do endovascular repair, TEVAR, rather than continue these patients on medical management. We also came to know that it is better to offer TEVAR in subacute phase rather than chronic phase, subacute phase rather than acute phase also. We'll come to that. So the management schema changed by 2015, that if you have type B dissection, but you have complications like aortic rupture and or organ ischemia, continuing pain, hypertension despite full medical therapy, hypotension, early false lumen expansion in first 2 weeks, large single entry tear, then these were the indications where you go in endovascularly and perform a TEVAR. If all these things are not there, then that is real uncomplicated type B, and then you continue with medical treatment. But this is not enough. Now we have more data, and that is those type B who are kept on medical management, who were uncomplicated to begin with. When they become chronic, they show aortic inflammation, sometimes, not all, but many of them show aortic inflammation, which is picked up on PET-CT and MRI. And these are the ones who do not do better. These are the ones who start going downhill after 2 years and 3 years. So the Stanford Aortic Dissection Risk Calculator started calculating all these. Connective tissue disease, yes or no? Connective tissue disease means there is no endovascular repair. You straight away go for surgery. Maximum aortic diameter in the dissected aorta, circumference of the false lumen, identifiable aortic intercostal arteries in the area of the dissected aorta. What is the false lumen outflow? You calculate from left subclavian artery, celiac trunk, superior mesenteric artery, left renal and right renal, inferior mesenteric, all the visceral arteries, whether they are coming from true lumen or false lumen. And based on that, you calculate or give a score to all these points. And those patients who were high risk as per this score, when they were followed up over a period of 6 years, 5 years, they showed significant difference in survival. Even other things that when those patients were given TEVAR, an uncomplicated type B, the remodeling was better when it was done in subacute phase, or when they were complicated, it was done in acute phase. So basically, we used to be taught like this, that there is a type A and there is type B. It is complicated and uncomplicated, and uncomplicated has mortality rate of 10% if managed medically, and uncomplicated has a mortality rate of 58% if managed medically. So that's why complicated should be treated, uncomplicated should not be treated. But that has changed, because type B dissection does not necessarily remain uncomplicated. That also evolves or devolves. So the dissection is an ever-changing disease. Essentially, there is no one who is not at risk. Temporal survival by acuity, you can see the separate curves as the years go by. And to say the least, there is big impact on the lifestyle also in those uncomplicated aortic dissection who are managed medically. So the future management schema, or 2021 schema, if you will, looks like this, that those uncomplicated type B dissection on the right bottom corner, even when they are deemed low risk, there are no high risk parameters. You do a pre-discharge CT at 7 to 10 days. You look for high risk parameters like false lumen expansion in those 10 days. Repeat the CT at 3 months. If there are no high risk parameters, reassess and do a CT follow-up protocol. And the moment you feel that this uncomplicated low risk type B aortic dissection is changing into high risk, you do the TEVAR. So to conclude, as the Pope said, God created the aorta with only one canal, and that's how it should stay, because he was treated for this. Thank you.
Thank you, Dr. Sameer, for the excellent deliberation. So the conclusion is that type B, despite being uncomplicated, should be treated endovascularly as and when possible.
Whenever you feel that it is high risk.
Thank you. Any questions, please?
Thank you, Sameer. What I'm just saying is some more of a comment rather than a question. I think unlike type A, where there is an underlying disease for that dissection to happen, type B is most often a hypertensive disease. And therefore, I think enough emphasis is not being given to the root cause. And therefore, aggressive antihypertensive management has to be emphasized at every single deliberation of ours regarding type B aortic dissection. As you rightly say, the numbers have increased. That is also because the age has increased, the overall age, and the detection has increased, as well as hypertensives has increased. And I think prevention ultimately is the best, especially in type B, and an aggressive antihypertensive treatment ought to be deliberated on.